So station 1, I'll read the question. I'll try to answer these questions. Professor Dimri sir can correct me if my answers are wrong or if he wants to add on to it. Is it okay, sir?
Yes, that's very good. Yes.
Okay. Coming to station 1, a 30-year-old man, a known epileptic, was referred to the orthopedic department with the history of inability to move his right upper limb properly. On examination, the right upper limb was lying across the chest and could not be brought into external rotation. So the questions are, what could be the likely diagnosis? Can there be an associated nerve injury? And which nerve? The X-ray showed AP view with the normal to the intern. However, the senior resident could not make the abnormality described typical with dash appearance. And what could be the management of such case? Before I start answering, I request all the students to go through all the questions, because you might find clue in the later on questions. That's the reason I've gone through the entire questions. So with this, I'll try to answer this question. Epileptic injury, a known case of epilepsy with the right upper limb lying across the chest, most commonly denotes it to shoulder dislocation, that is posterior shoulder dislocation. And yes, there are chances of nerve injury, and most commonly the axillary nerve. The AP X-ray looks normal to an intern, but an only trained eye can recognize light bulb sign, that is a typical appearance. And what could be the management of such case? Any dislocation that needs to be reduced, either closed or open. Trial of closed reduction has to be done. If not, open reduction has to be done. After that, we need to take further management in terms of X-ray and CT scan to look for any instability because of the reverse Bankart's or bony lesion. Is that right, sir?
Yes, yes, that's very good. Those are the model answer we would require. Again, management-wise, because it's not mentioned whether it's a chronic case or recurrent case. So first thing is closed versus open reduction, and then assessment for mainly two important reasons: reverse Bankart and reverse heel sac. And then accordingly, if it causes recurrent dislocation, then you deal with that problem later on. So you could say management of closed open reduction, followed up by assessment for reverse Bankart and reverse heel sac. That's it.
Okay.
So that will complete everything if in the management they have something different there.
Okay.
So good.
Yes. Now we'll go on to the next station. Station number 2, a 25-year-old male had a history of injury to right elbow 1 year back. He is unable to move his joint freely. On examination, the elbow arm is only 30 degrees. The 3 bony point relation is disturbed. However, the base of the triangle is comparable to the opposite side. There is no tenderness, no supracondylar ridges are thickened. What is the likely diagnosis? What is the prominent structure seen in the picture? That is the picture which they have shown with the white yellow color marking there. They have pointed a bony landmark of olecranon. In the normal elbow joint, describe the range of motion required to perform activities of daily living, and discuss briefly the management options of such case. So here, with this history, 3 months old history, with maintaining the base of the triangle, I think the diagnosis is neglected posterior dislocation of the elbow. The prominent structure seen is, since they have mentioned the olecranon, the soft tissue which is attached to olecranon is triceps tendon, that is the triceps insertion. In the normal joint, the described range of required to maintain the activities of daily living is about 30 to 130 degrees. And discuss briefly the management options in such case. Since it's again the question is based on dislocation, any dislocation that needs to be reduced, either open or closed. Since it's already an old injury, so I'm suspecting it to be require open reduction with release of soft tissue all across. And depending upon the stability, we need to think of ligament repair. Sir, is that right?
Yes, that's absolutely fine. Again, in the management, because it's a elbow become very stiff very quickly. So some people even start calling chronic dislocation even at 2 to 3 weeks. So this is very unlikely that you'll able to reduce it closely. So the treatment will be open reduction with liberal soft tissue release, which will be capsule and ligament both of the time. And remember that structure is pointing to the prominent structure number 3. Why it is pointing is that this structure become quite often very tight, and you might have to do lengthening of the triceps. So good soft tissue release of capsule and ligaments, lengthening plus minus lengthening of tricep, and at end of your procedure after reduction, assess the stability. And depending on if it is unstable, then either you may put a hinge fixator, or some people, controversial, do ligamentous reconstruction. So these are the sequence you have to say. Open reduction, liberal release of capsule ligaments, then plus minus ligamentous reconstruction, plus minus hinge external fixator.
Okay, sir. Moving on to the next station. Station number 3. A child presented 3 months after the injury with an X-ray picture shown below. The questions are: what is a radiological diagnosis? Write down the three cardinal features likely to be found in the examination of this elbow. What are the indications or the contraindications of surgery after 3 months of injury? What are the complications of surgery? And what are the sequelae if non-operative treatment is opted? So the last two questions, D and E questions, they are, last C, D, E questions are indicating towards surgical management. Thinking this clue, and X-ray is given only AP view, which is not seems to be proper to make any diagnosis. I'm thinking both in terms of first diagnosis would be of dislocation or lateral condyle non-union, but I'm not aware of the proper view. So I like to ask Professor Sir, what should be the answer for this, ideal answer?
Okay, so this is a slide has been kept because sometimes the slides may not be very good in the exam, and we want to mimic that situation. We could have changed these slides to easily to a very clear slide. The reason is that sometimes you need to read the question and then see what possibly it could be, because this could be anything. Just on AP view, the olecranon, the ulna looks quite medial, and you don't know where the radius is. So then you have to read, as Vishal was saying, the question and have a good guesswork of it. So you know the question sequelae of non-operative treatment is asking, complication of surgery is asking, what are the indication, contraindication of surgery after 3 months of injury. So again, very unlikely that this will be a dislocation problem, likely to be a fracture position. And if you see, it is seeing that there is some lateral mass which seems to be separate from it. So for me, it probably is a question of again 3 months is for a lateral condyle. Some people start calling non-union at 3 months by definition, but to be safer on side, you can always say ununited lateral condyle fracture. So once you got the diagnosis, then you can ask answer rest of the questions. So what will be the answer for B?
For a non-union lateral condyle, creptus will be there, sir. The 3 bony point relationship will be maintained with, the lateral thickening and creptus abnormal mobility. I can find it out. Elbow restrictions will be there, and the soft tissue swelling, bony prominence will be there, but not, since it's a 3 months. I'm expecting the swelling to be very less. Is that right, sir?
Yes, so you need to just now, once you made a diagnosis, then you have to just describe what lateral condyle is. Non-union will be, so it may be painful, it may be mobile, so you can move the fracture fragment. Your lateral condyle ridge will be quite rough. The triangle will not be maintained, especially the base will be widened because it's displaced. All these finding, you can say 2 marks, so you can write down 3-4 finding, and that should be enough. Decreased range of movement is common. Stiffness is common after non-union lateral condyle. So these are the things you write, right? Yeah. So indication, contraindication, surgery after 3 months of injury. So basically this child, although again difficult to see, but looks quite young. So it is unlikely that there'll be at 3 months you will not do anything for this. So what will be your answer, Vishal?
If there is restriction of movement and there is no myositis mass or no history of any massage or something like that, I like to go for surgery, sir. Or if there is no restriction of movement and patient is asymptomatic, I tend to uh, I'll not go for the surgery. That is
Yeah,
the
so the question comes because we don't know the age. Let's say this patient is about to be skeletal maturity and he's got good range of movement and reasonably asymptomatic. Would you do surgery?
no, sir.
Okay, so you need to know also what is the likely of developing future deformity in these patients. Yeah,
Yes, sir.
you also need to know that what intervention so far has been done. So if it is, as you rightly said, so the only contraindication will be if patient is completely asymptomatic, nearly skeletal maturity, or there's a lot of stiffness and myositis, so you will wait for that. These will be contraindication. Then the rest all become indication. What are the indication then? Young patients who can likely to develop deformities. This fracture is mobile and painful and or already causing deformity, then these are the indications. But 3 months is unlikely, but so 3 month indication will be painful, mobile fracture in young patients with no contraindication, which we have just mentioned.
Yes. So, okay.
What are the complication if you do at 3 months?
Chances of again going for non-union are high, sir, and chances of stiffness, facial arrest, and leading to the deformity.
Yeah. So, what is the main precaution we tell people when they trying to reduce a non-union supracondylar? What is the main problem, and what is the main precaution we take? The main problem we tell them that when you go, because you need to release quite a lot of soft tissue to get it back to where it belonged to, and for that you may have to strip quite a lot of tissue. So, and especially if you go on the posterior aspect of it, all the blood vessels come there. So there can be an avascular necrosis. Okay, so remember that. So yes, non-union is possible, but non-union could be also because of AVN and then leading to non-union. So AVN, non-union, stiffness, these are the common one, and then you can keep adding to it infection, future deformity, and things like that. And yeah.
Yes, sir. I think I have underperformed this station probably.
So what is a complication of surgery? What are the sequelae if non-operative treatment? So what are the sequelae?
Uh, Non-union stiffness and deformity.
Yeah, and what deformity?
Cubitus varus or
Well,
cubitus
mostly cubitus
valgus.
valgus, you will say, and leading to tardial nerve palsy.
I didn't know all of this. Yes.
Yeah, so if you mention these things, that should be okay.
Yeah. So
Although in remember in lateral condyle, you can have a false cubitus varus or pseudo cubitus varus because of the spurring or overgrowth of the metaphyseal. So it gives you an appearance of cubitus varus. And very rarely you can also have true cubitus varus. So you can have all three. You can have cubitus valgus, you can have spurring or pseudo cubitus varus, and you can have true cubitus varus. But if somebody asking you one, then cubitus valgus leading to tardial. Okay. Yeah.
so how much do I score in this station, sir? It's supposed to be tough for me.
Yes. So because and then the things are wrong. So at least you attempted out of 5, and 3 you were absolutely right. And even the other one you're saying, I just changed the sequence that what you should be telling. It's like avascular necrosis, complication of surgery if it is asking. So the examiner will have in his mind at avascular necrosis. Yeah. So that doesn't mean that stiffness is not a complication or infection, but those can come a little lower down. So you may score still quite high, but I am telling you what the examiner mind is going. When he's talking complication, most time what we tell our students, be careful, don't strip it completely. Yeah, don't try to make it, and this is one fracture which we tell you, don't try to make it anatomical on the articular surface, because what your aim is to get it healing on the metaphyseal surface. So that's what the examiner mind will be.
So moving on to the station number 4. Anyone, any student wants to answer this? Can I pick someone randomly, or someone wants to volunteer this question?
Dr. Naeem, you want to answer? Dr. Shushruth, Dr. Naeem, any one of the exam going students can answer this. At least tell us what you have written in the exam so that we can correct you.
Hello, sir.
Yes, Vijay.
Sir, evidence-based medicine has how many levels, sir? It is 5 levels, sir. Which is the highest level? Give one example. Highest level will be, sir, RCT studies, RCT or meta-analysis. And which is the lowest level? It will be case report. Okay. And impact factor, sir, I don't know.
The last question. We don't know what both the questions.
No.
Okay. Sir, would you like to answer?
Okay, so we have taken actually a lecture on evidence-based and stats for you. So if you want to quickly revise that. So basically the different book can say it's different, but you are absolutely right. The common accepted is level 1 to 5. So first question, evidence-based medicine, how many levels? There are 5 levels, 1 to 5, just say that. Which is the highest level? Obviously, highest level is level 1. And give one example. So you need to remember at least the 3 good level 1 studies. So those are your systemic review, meta-analysis, and RCT. Okay, so these are your level 1 studies. And then remember, level 2 be cohort studies, level 3 be case control, and then level 4 will be case series, and level 5 will be case report or expert opinion. So remember one in each, the good one to remember. So remember 2 or 3 for level 1. Level 2 is normally we say your cohort studies, prospective studies, and then come further level 3 case control, level 4 case series, and level 5 is your expert opinion or just one case. Yeah. So that is which is the highest level, and give example, which is the lowest level. You have given example. What is the significance of impact factor of journal? So already it is asking, even if you don't know, you can from this say that it trying to impact factor means showing how good is the journal is. So you can say it is there to compare the journals among themselves, that how much impact they have on the general evidence-based literature. And this is how. So what is impact factor? You need to know this little bit about how do we calculate it. So basically it is calculated on last 2 years. So any journal you got it, you can calculate impact factor. So on any topic, suppose you say there's a Perthes topics, and you find out how many are citable articles are there. And so suppose you have got in last 2 years 50 articles, and then say how many people have cited these articles. These are all we're talking about index journal. Let's say out of 50 articles, and over the periods 20 has been cited. So 20 over 50 become your impact factors for last 2 years. And then suppose it says 2008 and 9, you will say in 2010 the impact factor of this was 20 over 50. That's how you calculate it. Okay. And the value of impact factor is you can compare journal, you can make sure that in particular topics, which journal is giving you a better evidence-based. So this is all comparative, and they can get grant based on this. If you're working in a postgraduate institute, you can apply for a grant that we got a journal with impact factor so and so. If you have got publication in a journal, you can say we have published in a journal which good impact factor. So these are the advantages. Okay.
I think that this is very important topic to score the marks. This is because the last two question carries half of the marks. Not answering the first three questions, you get 6 out of 6 marks. You're getting 3 marks, and the next two questions carrying 3 marks. So you should be little what to say, careful in reading the questions as well as the topics on this kind of topics. Reading the entire thing, impact factor, and all apart from your regular thing. So moving to the station number 5, I think Naufal can come up with this answer. Pardon us for the poor image because these images have been taken from the few